Welcome to the Vanderbilt Eye Institute's Video Atlas of Retinal Diseases. This presentation is an introduction to pattern dystrophy, which is a name given to a group of dystrophies that affect the RPE. There are variable clinical presentations in this problem, but they all have similar genetic mutations. Other times, patients are mistakenly given the diagnosis of early macular degeneration, so it is important for you to recognize this particular entity. We will briefly discuss the demographics and a typical presenting history. Then we'll spend just a few words on the genetics and histology, and then finish with some clinical examples and show some examples of the differential diagnoses of pattern dystrophy. While there are 5 different types of pattern dystrophy, the most common type is known as adult onset foveomacular pattern dystrophy, or AOFP. It is also known as adult Best or vitelliform macular dystrophy. This is the one that we'll be concentrating on today. The other 4 types will be presented at another time. Different patterns may be manifest in the same family, or over time, a patient may morph from one style of pattern dystrophy into another clinical presentation. Most patients with adult onset foveomacular dystrophy are asymptomatic until they're in their 40s or 50s. The onset is gradual, and they complain of a mild visual blur or metamorphopsia. Sometimes you will come across a patient in their 60s who says that they've had macular degeneration for 15 years. Well, that'll put the onset in the 40s, and that is early for macular degeneration. So on these patients, be alert that pattern dystrophy may be a possible or actual correct diagnosis. While there are many different clinical appearances and presentations to pattern dystrophy, they have a common mutation in the PRPH2 gene, or the RDS gene, or the bestrophin 1 gene. Pathological studies have shown defects in the outer disc segments, which lead to a secondary change in the pigment epithelium. There's also a loss of the photoreceptors, and pigment-laden cells can be seen between the photoreceptors and the pigment epithelium. Occasionally, you can also see pigment in the outer plexiform layer, and there's a buildup of lipofuscin in the RPE cells. The typical and most often presentation of type 1 adult onset foveomacular dystrophy is a vitelliform lesion in the fovea. Usually, they are between 1/3 to 1 disc diameter in size. Occasionally, they will have a dark spot in the center, and this is seen easier with backlighting with the slit beam. There can also be some parafoveal yellow spots as well. Here is a typical clinical presentation. On the left slide, you can see the yellow spot centrally in the fovea very easily. Notice the lack of drusen, and this helps distinguish this from macular degeneration. The right slide shows the central vitelliform lesion with a typical dark spot in the center. Sometimes these dark spots are seen easier with backlighting than with direct illumination. Here is a highly magnified look at another patient. Notice not only the vitelliform lesion and the very faint pigment centrally, but also the small yellow dots surrounding the fovea. Here is the OCT of this patient. It corresponds well with what one would find on histology. The OCT typically shows a hyperreflective area between the photoreceptors and the pigment epithelium. Occasionally, if the patient has pigment migration, you can also find hyperreflective spots in the outer plexiform layer. The right slide shows more involvement and more hyperreflective material at the level of the RPE than on the right eye which is on the left slide. Here are some different presentations of type 1 pattern dystrophy. The upper left photograph shows the pigment with a yellow halo and some very faint yellow deposits. The upper right slide shows that some of these yellow deposits later can themselves become pigmented. This pigment may be at the level of the pigment epithelium, or it may be in the outer plexiform layer, as discussed earlier. The lower two photographs also are pattern dystrophy, but they have larger vitelliform lesions. There's a long list in the differential diagnosis that you can look up in other atlases, such as the Ryan Atlas or textbook, or Gass's Atlas, or look it up online. The most common in the differential diagnosis will be macular degeneration, followed by pigment epithelial detachments, central serous, or a lamellar hole. For a more complete discussion of this, look at the chat titled The Yellow Fovea. The differential for subfoveal OCT changes similar to pattern will include macular degeneration and pigment epithelial detachments. This slide shows some of the differential OCT diagnoses. The top left slide is pattern dystrophy with the pathology at the level just above the RPE cells. The top right shows multiple pigment epithelial detachments. Note that typically the RPE elevations are hyporeflective in a PED, but it's hyperreflective in pattern. The bottom left photograph shows multiple small drusen, and the bottom right shows what is called drusenoid pigment epithelial detachments. In summary, pattern dystrophy usually begins in the 5th or 6th decade of life, which is 1 to 2 decades earlier than typical macular degeneration. While there are 5 different clinical morphological presentations and sometimes different manifestations in different members of the same family, the genetic defects are similar. And finally, it is important to distinguish pattern from macular degeneration, as pattern dystrophy has a very different prognosis, and the patient should be informed of the better prognosis and not be worried about going blind with this particular problem.